where the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, good morning, everyone. Welcome to UroNurse. I'm your host, Vic Senese. Glad to have everybody here today. Hey, if you're watching us, be sure to hit that like and subscribe button. You know, that helps us out. So today we're going to have a great show. I've got Dr. Jordan Barber joining us, a New York City-based integrative medicine specialist known for blending traditional medical science with holistic, patient-centered care. Dr. Barber brings a unique perspective to healthcare, focusing not just on treating disease, but on optimizing overall wellness through lifestyle, nutrition, and mind-body approaches. With a passion for helping patients take control of their health, Dr. Barber works at the intersection of modern medicine and integrative therapies, offering practical strategies that support long-term healing and prevention. So we're excited to have Dr. Barber with us today to share insights that can help both clinicians and patients think differently about their health and wellness. Dr. Barber, welcome to the show.
Thank you for having me, Vic. It's great to be here. And
Yeah.
Thanks for that introduction.
Hey, the best thing I could do is I use AI a lot. It writes all my scripts for me. So yeah, let's get right onto your show because we're anxious to hear more about this. So I'm going to bring up your slides and you take it away.
Awesome. So the question we're posed with here is, can acupuncture actually help with sexual pain and pelvic dysfunction? So I'm Dr. Jordan Barber, and my doctorate is Doctorate of Acupuncture and Oriental Medicine. Let's just get the disclosures. I have none. For just transparency, my clinical focus is musculoskeletal and pelvic floor dysfunction, and I utilize dry needling within acupuncture practice, which we're going to cover today. And obviously, clinical judgment and individualized patient care is yours. This does not replace it. So before we get into it, can acupuncture do it? We should probably say, what is acupuncture? Everyone has an idea of what it is, but you know, I'm probably going to burst that bubble. People think of acupuncture, you think of mystical energy, meridians, qi, all these different words. That actually is not the most accurate thing, and that is all due to one French bank clerk in around 1910 named Georges Salé de Marant. Was not a physician. It was also the height of the spiritualist movement in the West, and he wrote a book with good intentions, and he coined terms like meridian and energy for qi. And it stuck. So it created a baseless energetic model that was not how it was ever seen. And that's kind of how it's been perceived since. But there's a neuroscientific reality to it. The ancient texts where acupuncture comes from describes specific vascular networks and neural pathways. And the acupuncture points are highly concentrated neurovascular nodes. There's a sensation that occurs when you needle. We call it the qi, or means obtaining the qi. Qi is a very hard to translate word, but we could say in this case a sensation or an interaction between the bottle. And that can confirm sensory perception of specific nerve fibers, such as A delta and C fibers, which are now reaching the central nervous system. So it's showing that there's an interrelationship occurring when we put in the needle. And we're going to look at that and how it can regulate urological issues and pelvic floor dysfunction. So I also use the term called dry needling. Dry needling is just a subset of acupuncture, and it's focused on muscle and nerve function. It uses acupuncture needles, same exact needles, and we needle directly into muscles and connective tissue to target trigger points, which are tight, overactive muscle bands, and regulate nerve function. It's based on modern anatomy and neurophysiology and not the mistranslated energy concepts. And it is part of acupuncture's broader system, but it is often used by physical therapists, chiropractors, depending on state regulations. And what does it do? It reduces muscular tension, guarding, modulates neurological signals, improves blood flow and tissue oxygenation, and helps restore movement and function by taking out tension in the system and regulating biomechanics and kinetic chain and functions, which is super important to the pelvic floor. We'll talk about that in a bit. So if we just look at a quick comparison, dry needling is a focused anatomical-based subset within a broader practice of acupuncture. Acupuncture still addresses these trigger points, and there's different ways. But one of the key differences is that within acupuncture, typically in a modern sense, you'll see that we retain the needles, and it's based on a large interrelationship model. Dry needling, we're hyper-focused, focusing on those specific muscles or regions, and we don't retain the needle. We stimulate it until we get what we need, like a localized twitch response, a depolarization of the muscle, and then we remove the needle and move on. But both are quite effective when used appropriately. So just to summarize, acupuncture is not energy-based, although we still use the words, and it is fun to think about. It is a direct system interface with the peripheral nervous system. There's a sensory confirmation from the central nervous system via the A and C fibers, and it is analogous to neuromodulation, which functions as mechanical and electrical gateway to alter nervous system signaling. Hopefully in your mind, thinking about different urological issues and pelvic floor dysfunction, that might be somewhat useful. And I am from New York, so I talk extremely fast, but I also have a lot of slides. So I want to just define pelvic floor dysfunction and pain contextualized within this concept. It's a large area. Right. So one of the things that you may see in urology all the time is this diagnostic gap. Everything looks normal, but it hurts. Imagery, labs, testing are completely fine. But yet there's still high prevalence of debilitating pelvic pain, sexual pain, when there's no pathology or structural issues. What do we do? And essentially what we see is this vicious cycle of pelvic floor overactivity and sensitization. You'll have noxious stimuli, right? Some sort of pain, going into some protective muscle guarding, right? Which therefore creates hypoxia and ischemia, which alters local blood flow, which will lead to neuroproliferation, which increases sensitization, peripheral sensitization, central sensitization, and it goes on and on. And there's a chicken before the egg, which once starts, doesn't really matter. Once it's there, all these things start cascading. So how do you help the person? That's the real question. So one of the things that are overlooking is muscle-driven pelvic pain. And this is a major overlap with pelvic floor PT, which I feel is the gold standard to most of this stuff. And I feel that acupuncture and dry needling are adjunctive modalities to it and have a strong place. And the outcomes are huge when paired together. But we have a high prevalence of trigger points that can have different symptoms and mimic urological conditions, right? And again, trigger points are hyperirritable bands that have two distinct things. They have referral pain patterns, and they have autonomic dysfunction, which means that they create neurological dysfunctions when there's tension in there. And that is via the musculovisceral reflex of the nervous system. So when we start looking at trigger points and the pelvic floor, there was a paradigm shift via Wise and Anderson. Early mid-90s, there's the Wise-Anderson protocol that really was established around 2000, 2003, somewhere around there. It used to be known as the Stanford Protocol. And it's really just looking at how dysfunction is kind of a systemic issue, and there's a muscular component to it, and certain muscles have direct effect on the pelvic floor function as a whole, including the genital urinary system. So they looked at physical interventions, trigger point deactivations, neurological interventions, CNS downregulation, using the downregulating the sympathetic nervous system into the parasympathetic, and looking at a multimodal approach to treating pelvic floor pain, chronic pelvic pain syndrome, and other conditions that are there. So we can see that there's a foundation for having a neurological, muscular, biomechanical approach already established with a strong neurological connection. And when acupuncture is neurological medicine, we start seeing that there's a major advantage to incorporating acupuncture and its subset modalities. So what does it do? If we're looking at dry needling and applying it to the Wise-Anderson model, you cannot change the pain output without physically changing the mechanical and neurological input. We have to break guarding reflex. We have to direct mechanical access. So we get in there with dry needling or PT. Often in PT, sometimes things are hard to deactivate. The patient might be plateauing. We can get in there and neuromodulate and deactivate the muscle sometimes a little more specifically and allow that treatment plan to progress, which is incredible when you see the synergistics between physical therapy and these modalities. We get this mechanical downregulation, and we get a neural downregulation, and suddenly we reverse that cycle that we saw previously of that constant pain cycle that just continues to be a positive feedback loop, but there's nothing positive about it. So what's that urological impact of pelvic tension, right? Mimics organ disease. Muscle spasms frequently present as prostate, bladder, urethral issues, but everything's fine. You know, we see urinary urgency, high frequency, pain, burning during and after urination, mimicking prostatitis and interstitial cystitis. These pelvic floor muscles can actually physically constrict the urethra and irritate the bladder. Trigger points can compress local nerves, sending false emergency signals to the brain regarding bladder fullness or pain. So when everything looks normal, we got to think biomechanical and neurological. So how do these needling-based modalities help? That would be the question. Well, if we go back into neurology, and I will spare you most of the boring stuff, but you know, we have these different things: dermatomes, myotomes, and visceral tomes, skin signaling, muscle signaling, and visceral signaling. They all interact at spinal segments related to those perspective or different areas. So we see that signals from one area have an interrelationship with the other areas, and we can modulate organ reflexes by working with the or muscular visceral reflex, the cutaneal visceral reflex. These are stimulations of muscles and stimulations of the surface and skin to move past that reflex arc at the spinal segment and start modulating the visceral pain or visceral function and sympathetic tone. So there's an easy way to start interacting with these things when there is a presence of pathology. So we can look at segments, right? We look about T11 and L2, we see that it has the sympathetic control of the kidneys, bladder, the upper bladder, ovaries, fallopian tubes, uterus, and testicles. So working with the dermatomes and working with those spinal segments neurologically can have a strong effect. And we'll see how that works, right? We have mechanisms. So we have a mechanism basically where we can focus on the axon reflex, which will release CGRP, which is a vasodilator, which releases histamine, which increases permeability of all the other chemicals there, and releasing nerve growth factor for rapid tissue repair, which also can repair the nerve tissue, especially in cases of segmental dysfunction, herniations, tissue injury, or long-term hypoxia of the tissue. Also, using electroacupuncture, we can actually use specific frequencies and pulse widths to modulate specific tissues, which we'll get into more, but that triggers profound releases, ankylphalline, serotonin, norepinephrine, which chemically gates descending pain signals into the pelvis. So we just look at that. We have a mechanical insertion, or we can even attach electrodes to the needle. Once it's down there, it has an axon reflex, releases CGRP, which creates this rapid release of a healing matrix and repair cascade of different peptides and transmitters. So then we have a second area where we look at S3 to S4, and from there you have the infamous pudendal nerve, which is lower bladder, prostate, external genitalia, and pelvic floor musculature. So this is the definitive area that we would focus for overactive bladder, incontinence, prostate inflammation, and pudendal neuralgia, as well as other muscles like obturator internus that compress the pudendal nerve and create different pain as well. So in urology, what's the applications? We could deactivate the trigger points, which are traditionally known as ah, sure, which literally translates, ah, yes, it hurts there. If you push on it, you're like, ah, yeah, that hurts. That's the spot, right? And that can decrease the referral pain and autonomic phenomena that can mimic UTIs, interstitial cystitis, etc. So these precise dry needling or modulations of the effect can exhaust those trigger points and deactivate the cascade that causes those pains. If we look at the visceral tomes, We discussed them quickly before, the T11 to L2 and S2 to S4, but essentially deep intramuscular needling and paraspinal needling at these exact segmental levels with or without electrostimulation, especially if we need to neuromodulate, can regulate dysfunctional urological reflexes. So super useful. And just looking at kind of a unified clinical synthesis, we have local effects where just needling in the area can regulate certain cutaneal reflexes, as well as deactivating the trigger points. We have segmental approaches, which gates pain signals, as well as helps restore function over time by repairing tissue, by signaling certain hormonal cascades in the area and neurotransmitter cascades. And then we also have the CNS that's constantly reacting to it via the PAG, the paraductal gray, which regulates essentially pain and anxiety centers in the brain. So this is the area that we start seeing somatic relationships, and especially in histories of trauma, as well as working on the endogenous opiate circuit, the EOC, which works on secreting and regulating endogenous opiates. So we can create analgesia, especially in CPPS. So there's also Hilton's Law, which says how this stuff works. So pelvic dysfunction is a regional ecosystem. Hilton's Law essentially says that a nerve supply that supplies a joint also supplies the muscles that move that joint and the skin covering those muscles. So any sort of pain or dysfunction can create referred guarding, and therefore treating any of those tissues can also treat the other tissues. And that's all because they're all interrelated, if you remember the slide on the tomes, at the spinal segment. So you can regulate one via the other. So pelvic floor can not be treated in isolation. Dry needling or other things directly modulates these neural pathways of the deep pelvic joints and organs. So we also have central sensitization, which I think is something that is getting more attention these days, which is essentially that the CNS becomes overreactive, lowering the threshold of pain. Direct needling and neuromodulation can decrease the central sensitization and therefore bring signaling back to a normal potential. And that is via the dorsal horn through the gating of pain. And I'll spare you all the details, but essentially we can re-regulate the mechanism where pain is perceived and slow down C fiber signaling, which is the specific fibers that are receiving pain. And actually, interestingly, we can change pulse width on electrostim and actually recruit specific fibers. So if we only want to work with C fibers, or really work with specific forms of A delta, A gamma, et cetera, we can actually hyper-focus and be very direct targeted on specific fibers depending on what a person's feeling, because sharp versus burning versus dull and achy are different neural fibers. So when we're trying to have a diagnostic matrix in this biomechanical central sensitized world, we look at deep ache and heavy and crampy being muscular, sharp burning, radiating electrics, peripheral, and widespread, persistent, and migrating, central. And they can be treated in different ways, but I would say that patients aren't really in isolation. They are always a complex mix. So if we just want to back out, we want to look at everything we just kind of covered in like a vulvodynia model, right? So often not a singular tissue injury, it's continuous neural proliferative feedback loop. Any of these things can start to happen, and then ultimately they will lead to the others. So let's just say you were, I don't know, working out in the gym or had an injury or even a car accident, you had some sort of muscular issue, and that leads to myofascial hypertonicity and ischemia. That'll eventually lead to neurological reactions, and central sensitization or proliferation, and it will actually lead to ischemia, and that ischemia can even increase the neural proliferation, which is one of the main issues of vulvodynia. Then we lead to central amplification, where we start seeing the dorsal horn sensitization. I see my slide's a little messed up. When we're going here, will lead to central amplification. Again, it should be peripheral and then central sensitization. But ultimately, we have this cascade. But the great thing is no matter what we do, is when we interact with this, we start breaking that infinite feedback loop. So one of the other things that I was talking about, neuromodulation, it's a kind of an interesting word. It just means to modulate the nervous system, upregulate, downregulate, or bring it back to a homeostatic balance. You know, we can use 2 hertz frequency to trigger enkephalines and beta endorphins. So we can use 100 hertz for nerve transmission issues, which are much more targeted. And then I did discuss that we can even use pulse width to recruit different fibers with different frequency sets. And there's other ones as well. And this is just, nerves fire electrically. So when you are functioning at the exact same rate or level that they are functioning at, you can interact with them. That was super, super fast, and I hope you all understood that, but I'm going to open it up for Q&A sessions and see if I can bring some clarity to everything.
Yeah. Excuse me. That was really good. So I have a few questions.
Love it.
If we're just starting out and I'm trying to explain to a patient, hey, I'm referring you over to see Dr. Barber, they're going to want to know what they're getting into. So can you take it from the patient's standpoint? What can they expect? How much pain? Where are these needles going? How long does a session last? And how many sessions will I need?
So, it's going to be provider dependent, first of all, right? A clinical approach and how they work things. Dry needling does have sensation. And that's something I really try to make clear. I mean, we talked about that Dutchy response. That's the engagement of the A and C fibers with the CNS, which means there's a dull ache and heaviness sensations. These are very thin needles, 32 gauge, 36 gauge. So they're very, very fine compared to what you may be using clinically. But when they engage with the CNS, there's a clear sensation. Or you're going into a hyperactive muscle, there's a clear sensation. Extremely tolerable, often akin to a deep tissue massage. That hurts so good is kind of the sensation. It's also a localized twitch response where we go into it and suddenly the muscle just twitches. It's like an eye twitch, not a big deal, but when your entire adductor group twitches, you're going to yelp. It doesn't hurt at all. You're going to yelp and laugh because it's just unnerving. But it doesn't hurt. It's fine. That being said, dry needling versus acupuncture, which can be a little more gentle, which still has certain effects, and neuromodulatory effects, which also is more gentle because it's just gentle current at certain areas. Your patient base, if they have strong active trauma, dry needling in and around that region can be very triggering. So it's something that I encounter a lot of times where even though the patient wants the modality, it becomes a really bad pairing. Any invasive therapy when someone has active trauma might not work. So you're going to look more neuromodulatory approaches and more broader approaches. But ultimately, as far as sessions in dry needling, I often tell my patients 4 to 6 sessions, we're going to get very clear results. That does not mean a cure. If you're not getting better and we're not seeing change at 4 to 6 sessions, because it's instantaneous, it's a quick change. Doesn't mean it's going to hold. There's biomechanical things. There's all these other things that are happening. We're not going to get better at the 20th session if we didn't get any change by the 4th or 6th. With acupuncture, it's a little different. With neuromodulation, we normally are coming in 2 to 3 times a week for neuromodulatory treatment. And that's because of certain effects at the spinal segments to keep those certain secretions of the different peptides and neurotransmitters high so we can have effects, especially when trying to heal nerves. And that we would say you start seeing effects 3 to 4 weeks. Sometimes you see effects very quickly. They just don't hold. That's what I would say, but it's very practitioner dependent. And if you're going to refer, you should build a relationship because it takes a village to treat pelvic floor dysfunction. I speak to all my PTs constantly. We are in constant dialogue.
I do have a question that came in here from Katie Bortel. We use acupuncture for breast cancer for pain and nausea, and it worked. They were on less medication after the treatment.
Yeah, so specific acupuncture points can actually regulate via the CNS, and you kind of have the background now, specific nausea areas in the brain, and therefore it can help them. I was working with an oncologist for a while, just doing cancer support, and often you can get more chemotherapy because the patient can tolerate it more. And that's the brilliant integrative pairing of the modalities. It's not going to treat cancer, but it can certainly help.
Yeah. So, I mean, urology has been pretty familiar with using needling type things. We've done tibial nerve stimulation for overactive bladder. That usually is a little tiny needle that we put down in the ankle. So for your type of acupuncture versus dry needling, are you doing the spinal nerves or treating pelvic? pain disorder.
Yeah. So we're focusing on both, and it really just depends on that clinical presentation and how you can access it. So when you're looking at PTNS, you're using what's a posterior tibial nerve, right? It's in the name, right?
Yep.
So that is a branch off of the sacral plexus, right? So it's a distal branch of it. So now you can actually create signaling at the specific distal branches, and then you can also pair it if you wanted at the roots as they're coming out at the spinal segments to create signaling. So you can actually get more neuromodulation if you want. That's one way of doing it. We can also go down and send signals at pudendal nerve branches. I have post-prostatectomy case. Well, actually, now post-prostatectomy is post radioactive seed. They're in remission, but they have just urgency, and nothing is wrong, and nothing can work. And I wasn't getting anywhere doing a biomechanical approach. I thought it was a lot of muscles creating signaling, poor posture. When you get old, things just don't hold like they used to. It didn't work at all. And so I said, let me just try neuromodulation. And it was a Hail Mary play. I just wasn't even thinking of it at that point, just because the clinical signs seemed muscular. We'll put a nerve at the we'll put a needle at the perineum, put electrodes there, and connect it to the sacral plexus. And then also from the spinal segments of T11, T12 down to the sacral plexus. And we run certain frequency sets over time. And it has been a night and day quality of life change. Not curative yet, but like substantial change in signaling. So that's kind of an example how that would work in a, treatment.
Yeah. I do have another one here that came in. Can acupuncture help with common sexual concerns like erectile dysfunction, low libido, or painful intercourse? What does the evidence say?
Yes. That's what the evidence says. No, so it is short. So again, etiology is the question, right? Anything can help with anything when it's applied to the right case. So the adductor group is huge in blood flow to the pelvic floor. And when the adductor group is super tight, it can create erectile dysfunction. Also, a lot of erectile dysfunction is treated through adductor needling, especially for younger men who are active, right, who are doing deadlifts and everything else. Whereas, sure, if you had cardiovascular disease and you were having blood flow issues, I wouldn't say it is the best modality for it at that point, although there's going to be decreased neurological signaling because of that decrease in peripheral blood flow over time. So we may try to upregulate the signaling, could help. Also, acupuncture is a broader term for Chinese herbal medicine as well, and there's a whole gamut of stuff that could help there. I'll leave that to another conversation. And therefore, for vulvodynia, for painful insertion, for post-ejaculatory pain, some of these things are biomechanical and neurologically driven. But in certain cases with massive neuroproliferation or hormonal dysregulation, those need to be taken care of. And while acupuncture can help with hormones, it may be a more complementary case to bioidentical hormones or topical hormones, et cetera. Right.
So is there any evidence to say that needling can change hormonal levels, or?
There is significant, if you just go into PubMed and type, there's significant research. But again, things in isolation, as a published researcher, I understand the limits of studying acupuncture in the wild. Because if you say sham versus actual acupuncture, well, if we just discussed cutaneous visceral reflex and cutaneous muscular reflexes, any stimuli has an effect. And acupuncture, the place you put the needle was the acupuncture point. And then there were areas that we just knew were better at leveraging the system, which were these neuroplexuses or areas that were closer to neurofibers. So we realized there was more bang for the buck, for lack of a better term. So there is substantial evidence, even just looking at fMRIs and needling, seeing what areas of the brain light up. But etiology and case presentation has to be applied appropriately.
Yeah, absolutely. We've had a lot of cases in the past where patients come in, male patients, and they think it's prostatitis. They don't really have an infection, but they've got all these symptoms, and they're always coming in seeking antibiotics because that's what they've used in the past. And we've referred them off to pelvic, pain specialists, and physical therapists because they have such tight pelvic. You can just on a rectal exam feel how tight their pelvis is spasming, and they've had a lot of relief from that. I'm guessing things like dry needling may be a good
Huge.
adjuvant.
And I mean, I could think of a case of a younger male with took 8 minutes to void, no urgency sensations, but just decreased voiding, was undergoing pelvic floor PT, moderate effects, it does work, and was sent to me kind of, hey, do you have anything for this? And I was perplexed. We tried a few different things that we talked about, didn't really avail ourselves, although we had little effects, treating the attachments of, hamstrings and everything around the ischium, but not that much. Direct needling and applying quick current to bulbal spongiosis at the perineum changed it from 8 minutes to 2 minutes in a single session.
Wow.
Which is life-changing.
Impressive.
So
yeah, it is.
In place, but getting it right, that's in the clinician's mind. It's an art.
So do you feel there's a lot of pushback on people approaching this needling and acupuncture and all those things, because it's really not what we traditionally learned back when I went to school? And but I can tell you that I've seen it in real life where people have improved from it. So what do you think is the holdup for getting people to see you?
Well, I live in New York City, so we're very progressive in all ways and very embracing of these things, and we've seen it. The younger doctors are definitely for it. I've been at some sort of clinical care for over 20 years now, and I have watched when I first started where doctors didn't even want to talk to me, or they're just like, it's interesting, I guess it won't kill you, was kind of the words that I heard. To I have direct referrals from hospitals, I have direct referrals from urologists, and it's most of my referral base is PTs. So people want to help patients, and when things aren't working, they're like, what else can work? And when they understand that the practitioner is part of that team and speaks the same language, which the profession is learning to do, the acupuncture profession is young in the States, and we are still learning how to be part of an integrative professional society. Our schools are typically not part of large schools, so we don't get the cross interactions unless you do residencies, we do residencies normally in our own clinics. So we don't get that cross exposure, and I think that's a detriment to both because we don't know how to work together. But the doctoral programs are starting to bridge those gaps, thankfully.
Yeah. Well, it's great. It's been really interesting to hear a different approach on what we kind of commonly treat. Very similar type of problems that we're treating with medications and surgery can maybe be handled with something a lot less aggressive, such as needling. So it's fantastic to get your take on all this. I'm going to put a little promo for next week's show.
Are you confused by all the letters after a healthcare professional's name?
RN, NP, PA, APC,
DNP. What do they really mean? And how do these roles differ in patient care?
Join Vic, along with our group of experts, as we break down the key differences between registered nurses, nurse practitioners, advanced practice clinicians, and doctors of nursing practice.
Join us on April 4th at 9 a.m. Central Time to learn more.
Yeah, I'm looking forward to next week's show to kind of try to clear out some of these initials, because it's confusing for patients. It's confusing sometimes even for us with all the different practice levels that we have in our profession. And I'm sure you kind of incorporated some of that yourself too.
You're giving me ideas of my next article because no one knows. Within the profession, there's confusion, which I'm sure you guys have too.
Yeah. So I thought it'd be a great episode to kind of hopefully clear some of that out. I've got some really great experts throughout the country coming on board to talk about it. So thanks again for all your time and coming and joining us today, and I'm touching on a subject that we haven't touched on before. And I think it's something we're going to be looking at in the future again.
I really, really appreciate the opportunity to present this to people, and hopefully it's to the benefit of the patient's care.
Yeah, absolutely. All right. We'll see everybody next week.